talk like conversational, so please feel free to put questions in the chat, raise the Zoom hand, come off mute. We can make it conversational. I was going to spend about 20 or 30 minutes just talking about our approach at Mount Sinai to digital and AI transformation. I'll pull up my slides, but for a quick background on me, my background is in nursing. So I worked in critical care, medical surgical nursing, then in hospital operations. And then for the past 5 years, I've been serving the technology department. And then in January, stepped into the role of the Chief Digital and AI Transformation Officer. So in that role, I support our enterprise digital and AI programs, which I'll talk about today, and then partner closely with our research enterprise as well, particularly on the ways we translate research innovations into clinical care. And so I wanted to start with just this quote, because we have this experience-led approach, I think, that served us well, served our patients and our employees well, that digital and AI transformation has to start with experience. So every patient, clinician, and team member can thrive in the moments that matter. And for us in the technology team here, we didn't really have a competency in having user experience, UI, UX designers, and really having that approach where we can go out, hold focus groups, have qualitative, quantitative data around experience. And that's something that was new to us a few years ago. And I'll talk about today kind of how we're taking what we're hearing from our patients and from our care teams and from our employees, and then turning that into digital and AI products. I'll also talk a little bit about our evolution on governance as well. But for those of you who are not familiar with Mount Sinai, we're located in New York City. We have over 9,000 physicians, nearly 50,000 employees, over 400 outpatient sites. And we have a large research and education enterprise. So we have a school of nursing, a school of medicine, and a graduate school. We see over 6 million annual patient visits in our market. We're also proud of our digital metrics. So we're top performing on the what Epic calls their diamond benchmarks, for those of you who are familiar, and in some of the ratings out there, like the Newsweek World's Best Smart Hospitals, where we're rated for our use of AI, telehealth, and digital engagements. And so I wanted to talk about how we're thinking about supporting digital and AI across the different kind of personas that we have. And one thing that one evolution we've had on our approach has been to really structure the teams, the governance, and the work around certain key personas. And so starting with our patients and consumers, really to support different use cases for them. And I'll give some examples of how we turn some feedback from our patients into digital and AI products. Same for the care team. So like many organizations, I suspect many of you, we've been focused on ambience for both our providers, for our nurses, and for the broader care team. So that's one example of work that's come through our care team, part of our governance structure. Our workforce. So for a very long time, we talked about the digital front door for patients, but a new focus for us is around what are the digital tools to support the workforce. And so we're in build mode for a new AI-enabled intranet for all 50,000 employees when they come to work, with integrations into key systems, so that you can ask, what is our PTO policy? And you can get Gen AI will pull forward the policy, but you could also ask, what is my PTO balance? Or I want to put in this request. And we have integration with our ERP, with our help desk, with our policy and procedure manual, and with other key systems to create one front door for our employees for everything that they need to do. Also supporting our faculty and students who were the first to do chatgpt.edu. We're using that with our medical students and nursing students and faculty. And then supporting researchers. So work we're doing to accelerate both research discovery, but also when researchers build models, we have a process to move those models from bench to bedside. So we like to say from bench to the bedside to the back office. That's really the scope of our digital and AI governance structure. And so we had put into place a structure that starts with our steering committee, which is our top team. So our CEO, his direct reports, what we call executive leadership team, that helps set the direction. Our portfolio committee that's looking across the subcommittees. And then you'll see that these subcommittees we have align with the personas. So digital patient, where we focus on everything around scheduling access, billing, and the patient journey. Digital care, so all the AI that and digital tools that are in front of our care teams. The workforce, and then education and research. There's two committees that cut across. So risk policy and ethics help with things like they put out our enterprise policy on the responsible use of AI. They're consulted by the subcommittees, and then our assurance lab. And so assurance lab helps us to test models. We have a process to score, like what are the highest risk models from a risk perspective. And then particularly for the clinical models that are on clinical care, we take them through a prospective silent pilot evaluation and testing before they're deployed in use for patient care. And so this is all of our enterprise digital and AI initiatives come through this overarching governance process. And then we have an enterprise business-led roadmap around the problems that we work on, the problems to solve for the organization. One of the things that's been helpful is we built out our homegrown platform here that we run in Azure for doing advanced analytics. And so we've have the various kind of data producers, mainly Epic, but also areas like radiology, areas like our lab systems, incoming feeds that we get from wearable devices. And we're able to run our streaming analytics off those tools. And then from there, we have flexibility in where we send the predictions. We can interface into the Epic app ecosystem or directly into Epic, put it on dashboards. And I'll give a few examples of use cases, but having our own infrastructure where all the data leaves those data producers, we can run our analytics and then insert it back into a workflow has been really helpful. Because I'm sure for many of you kind of who do this work know that having something embedded in workflow is really most critical. And it's been really exciting, kind of like as the new models have come out and the latest advancements, our team just kind of testing out always like the latest and greatest LLMs. I would say that's been the fun part of this work. So whenever something comes out new for our tech stack, we get super excited. Our engineers have a lot of enthusiasm. But then for us, when it gets time to embed it into a workflow, that's where oftentimes we run into the challenge. So while we're so excited about that tech stack, I think when the human stack comes into play is where we struggle. And so 95% of the work oftentimes for these projects are around change management, right? And so oftentimes we're working with busy clinicians and they've done something one way for a very long time. We're asking them to do it a different way. And so a lot of our focus is on that change management function. And part of our team has been set up to make sure we're supporting our customers and have that customer success management arm really helping for any go lives that we're doing. And then the ongoing support and management for both our digital and for the AI projects. One thing I should share is that in the past, we ran two separate teams and committees. We had our AI governance over here and digital there. This year, we decided that it made sense to bring that together because the lines have blurred around every digital tool these days has some sort of AI or will soon. And so we felt like combining them made sense, both from a team perspective and for each journey, we have a set of agile pods. And then from a governance perspective, all of our AI and digital initiatives go through one centralized governance. And having that, having the experience-led approach and having designers and product managers that are experts in focus groups and user experience, user-led design has been helpful for us because we know that in the past, technology hasn't always lived up to the hype. And we know that our care teams are dealing with patients that are sicker than ever. And so we want to make sure that we're solving problems that are most aligned with our care team. So, these probably will sound familiar to many folks who are working in healthcare, the clinicians on the call around our redundant documentation, some fragmentation in tools. Sometimes the value of the technology is perceived to be low and some of the administrative overload. And one of the ways that we're trying to address that gap around what technology teams are deploying and how the clinicians are perceiving that deployment is staying really close to the work. We have a process where anyone in the organization can submit an idea for a digital or AI product. And we'll review those products, we score them, they go through our governance structure to select ones that we work on. And so one example of that was one of our nurses who was part of our wound ostomy and care team. So they spend their day looking at pressure injuries and caring for patients or helping us prevent pressure injuries from taking place, came to us and said, hey, I think that we could create a tool that does much better than the current tool we're using called the Braden score to flag patients at risk for pressure injury. And her name was Vicky. I want to introduce you to Vicky in a moment so you can hear about how she came to us with an idea. And we partnered to take that idea, co-develop it. We built the software and then deployed it in the EMR. And now it's a tool that we're using at scale. So here's Vicky. I'm going to play just a short 2-minute clip.
Pressure injury is a global issue. It's taxing our healthcare system when something is preventable. It is really important to prevent it from happening because prevention is easy, but treatment, taking care of it is really, really hard.
Hospital-acquired pressure injury costs millions every year to the hospital. It costs an extra $12,000 to $45,000 per injury when they happen for the hospital to cover the care cost. It's not reimbursed by Medicare, but Medicaid. Vicky came to us with the idea of having a predictive engine to be able to target the patients who are most at risk of developing a pressure injury before it happens and take preventative measures. We developed the model for many months and validated by everyone, data science side, but also clinical side.
The nurses doesn't have to be there. As soon as the patient arrives to the unit, even if the nurse did not see the patient yet, the artificial intelligence identifies patients at risk.
There was an increase of 9% of patients discharged without any pressure injury compared to before the pilot started. It's 50% more efficient at identifying the patients at risk.
We can roll it out to the Mount Sinai Health System. The whole system will have lesser pressure injury rates, and then bring it out to the public, to other facilities. And globally, hopefully, decrease pressure injuries globally.
It's really about getting the best information you can to make the clinical decision appropriately for the right patients.
I love to help people. I love to heal. I am excited when there's a wound and the patient goes home with no wound or healed wound. I am so, so happy.
So there you heard from Vicky, just an example of finding those enthusiastic champions, which has been so critical for our projects. And like there's a direct correlation with the enthusiasm and the engagement from the champions that we work with and the success of the project. So that's been a lesson for us, is just finding those folks that can really champion the work. And you saw there we paired Vicky with one of our data scientists, and they were able to build that on our internal AI platform and deploy it. Just to give you a sense of what it looks like, we make that prediction. We then interface it back into Epic for the wound care and nursing team. They can actually see this right on their Epic list. They can sort it by probability that the patient's going to end up with a pressure injury. We've learned over time that explaining the why, so in this case, we'll show the top features specific to that patient. You can see in this example, it's a mix of lab values, physiological data that's putting the patient at risk. So we can explain the why behind it, and then we can have very focused and tailored interventions, and we've seen this as a effective way to reduce our rate of pressure injury. That's same approach that we're taking on the clinician side, we're also taking on the patient side. And so we spend time holding focus groups, meeting with our patients, and going through a co-design process. And so, some of the things we hear from patients include just challenges with both navigating care, scheduling appointments, and some of the fragmentation of the digital tools. And one of the things that came out loud and clear in our research was that when it's time to seek care, many of our patients were feeling confused around, where do I go? there's a lot of options. Here in our market in New York City, not everyone has a primary care doctor. So you can go to your PCP if you have one. When you start feeling unwell, you could go to one of the EDs, go to urgent care, do a video visit. There's asynchronous care. There's a lot of options. And so we took that feedback and we co-designed a solution that we call Check Symptoms and Get Care. And so here's our AI symptom checker. We launched this almost 2 years ago. And we take patient symptoms. We use AI to match those symptoms to evidence-based triage guidelines, treatment guidelines called the Schmidt-Thompson guidelines. We partner with a company on this called ClearStep. So we've done the integration within our app, our website, and then for patients, they get a recommendation so they can be in the driver's seat around where to receive care. If that recommendation is you can meet with one of our virtual urgent care or primary care doctors, you can actually get right in the queue and to see a provider right within the experience. You can see an example here where a patient is feeling unwell, gets recommended a visit, and right within that experience can book their visit with their primary care doctor. So that's one example of listening to patients for their pain points and turning those pain points into solutions. We've done this over and over again, and that's brought us to a fairly sizable portfolio when it comes to our digital and AI products. This is a visualization of that portfolio. It includes AI we're using today from vendors, AI that we've developed internally, generative AI, and then robotic process automation agents that are live. The top half of the screen is our clinical use cases. The bottom half is back office, so you can see the most amount of use cases for back office. The right is our tools that are facing our employees, and then on the left are consumer-facing tools. So including our virtual assistant, the Check Symptoms and Get Care symptom checker that we just looked at. And so I'll give a couple of examples of throughout these quadrants, kind of what this looks like today. But it's a growing portfolio, and one of the challenges I think we have is just the velocity in which both these tools are becoming available through our vendors, like our EMR Epic, that we're getting requests, and that we're developing. So it's a rapidly growing portfolio. We've also been really focused on measuring outcomes. So in particular, for the products that we've developed in-house, we did a trial that showed for clinical deterioration to show that we can use AI to reduce 30-day mortality and hospital length of stay, which we've published on. We've built a falls predictive model that's reduced our falls per 1,000 patient days. We've published a lot on our malnutrition model that allows our registered dietitians to prioritize who they see across our 7 hospital campuses. And that's led to a sizable increase in patients we identify for moderate and severe malnutrition. And then patient experience, we've done some work to mine our patient experience data and get proactive around who's at risk for a suboptimal experience. There's a lot of data that was there around how long patients were either waiting in the EMR or how long we had them MPO. Some other data elements that was able to pretty accurately predict who's at highest risk for suboptimal experience. We can send in our patient rep team to round proactively before there's a complaint. Like many of you, we're also very rapidly looking at where we can get value from AI agents. And so we recently went live with our first set of agents that are in our contact center. They're able to help patients with things like confirming appointments, scheduling, canceling, requesting medications. This is an omnichannel experience, so the agent you can text, you can chat over web, over app, and over voice in the contact center. And we're seeing that more and more use cases, we're able to have the agent handle that end-to-end call. That way our human workforce can spend their time on the patients who really need an extra level of expertise. And so we started with appointment scheduling. We're moving on to medication requests. And then we're looking at some other opportunities to help support our patients with agents. It allows us to be accessible 24/7, where some of our services are only available during business hours. We're able to help patients on the overnights, on the weekends, or during hours where we're not always in business with our call centers that are there to support patients. I'm gonna stop. I'm gonna take a quick look at the chat, and then we'll end by talking about a couple more use cases, but also how we're assuring that the safe and responsible use of AI. So I've seen a few. I see a few questions came through. So maybe I'll take down the slides for a moment. Thank you for all the questions. Okay, the validation process. I'm going to talk about that in a moment. So we can talk a bit about how we do what we call assurance on the models. It's been a huge focus. And then how we score to know which models require a higher intensity of assurance. And then so how do you train your staff and providers to use technology that streamlines their workflow seamlessly? Yeah, I would say that for each project, we try and have the right training and change management to support based on the use case. So right now we're scaling up our use of ambient AI. And so every month we release a wave of a few hundred licenses. And then part of that is having folks on demand. So if you have a question on demand, at our larger locations, we have like elbow support, so someone available in person. But we learn each time around. So one of the things we learned that having someone standing outside the exam room just waiting for you to ask a question was actually like quite awkward for a lot of our providers and care teams. They just wanted to be able to press the button and get help when they need it. So the on-demand approach in that use case for ambient seems to work the best. But I think it depends on the use case. We learn with each one kind of what's the right intensity for training and to get the best adoption. The next question is, can you share an origin story of its implementation? An idea came from, oh, okay. I wonder if this question came in before the AI pressure injury use case. I think that was a nice one around, we got the idea from the frontline team. It came through governance, we vetted it. Some of the things we ask for when people submit the ideas include what is your success criteria? What are some of the metrics you can impact? It doesn't have to be financial ROI. It can be quality, safety. We use a framework called RICE to help make sure that we prioritize the highest impact work. And then every quarter, we look at what are we able to deliver based on the requests we get. So we get the request, it goes in our backlog, and then we have like a quarterly delivery cycle of what we'll work on over 12-week periods. And so in the pressure injury case, just to address what you asked around the success metrics, people do we ask for those success metrics up front. Oftentimes we spend some time meeting with the requester. And then in that case, the metric was reducing the number of hospital-acquired pressure injuries or bed sores. And then oftentimes there may be that's an important quality and safety metric for us. We saw that there was opportunity to improve. We looked at some benchmarks. We've published on this use case as well. We published on the model that we built to identify pressure injuries. And then there's also, when you can do that well, there's financial ROI because that's a preventable hospital-acquired condition. And there's different ways we can track the financial impact as well. The use cases that have financial and quality safety impact usually end up rising to the top. The other thing that's really important that we've learned is just making sure that there's operational readiness. So the teams that are going to work with the tool, are they ready to adopt the change? And that's where having a strong champion can be really helpful. Okay, let me keep going. How do you manage patients who are challenged with technology and language?
Really quick, someone asked if you could expand on the RICE framework a little bit and what that is.
Oh, okay. So RICE has it's an acronym. If you look it up, it's a well-known tool that's used for prioritization. It's around your reach, your impact. I'm blanking on the last two, but basically what we do is we'll look at how many patients can it impact, what is the total reach? Do we have operational readiness? And then also, do we have technical readiness? There are times where we want to work on a problem that we may not have the technical infrastructure. An example of that was we had a project around ventilator weaning where the chest x-ray was important in the model, but we weren't ready to consume those chest x-rays. So we had put that on pause until we were ready with our infrastructure to have a multimodal model that had, this one had a structured EMR data, notes, plus images. We've since deployed that one, but we're not always technically ready. But I would think the biggest one is generally the operational readiness. Are the teams that are requesting this ready to make time and engage in the work? Because oftentimes we're asking a lot of the teams that we'll partner with. We'll always have a working group, and that will usually require, in the pressure injury example, things like doing chart reviews, helping us with validation. There's a lot of effort that goes into creating these products. And so having the operational readiness and engagement is probably the most important.
I think I posted the link that I could find for the RISE framework.
Oh, thank you so
Robbie.
much.
Yeah, I think that's what it
Oh
is.
yeah, okay.
Reach, impact, confidence, effort, right?
Thank you. Yes. Reach, impact, confidence, and effort. That's right. Part of our impact is where we look at feasibility and technical readiness as well. Not rest size compression, right? That's a different RISE, Michael. Okay, I also have some questions that were submitted beforehand. Someone had asked around when you're working with ambient what do you do when there's a video service translator in the room? We're still working through that. That's actually something that came up recently. We don't have an answer just yet. And so TBD, what we'll do. And we haven't validated the ambient models for having a third-party translator. So we're doing, currently today, we're doing English and Spanish. We're not doing the other languages, but it's important to us. We have a lot of, we have a hospital in Queens that has more languages spoke than anywhere else in the world. So we have a lot of patients who don't have English as their preferred language, and that's something that we know we're gonna have to work through, is supporting beyond English and Spanish for ambient documentation. All right, I see one more question, and then I'll get back to the last couple of slides. Oh, how are you approaching AI professional development for clinical and non-clinical staff? Are there structured programs and learning pathways? Yes. So in our medical school, we have a department of AI and human health. And I partner closely with our chair, Dr. Krishna Karni, and we offer a few courses where you get a certificate. So one is AI for our providers. One is AI for our nurses. And then we don't yet have one for administrative staff, although we're working on that. So that'll be a future focus, supporting and training administrative leaders, administrative staff on different ways they can use AI tools. We have a couple self-taught modules on our learning management system, and then we're working with tools like Microsoft Copilot is the AI, kind of organization-wide tool that we make available. Everyone gets like the standard version, and then there's a process to request the version that gives you more detailed connections to like your email, calendar, and your OneDrive. Alifia.
Yeah, similar to the question on the education, are there any, like I'm sure you have use case specific training also for the end users as you launch these pilots? Like, are you the team maintaining like re-education as the staff turnover happens? How do you maintain like, scope of the AI use, or are there project teams within the department who were the project leads that sort of handle that?
That's a great question. I think it's something we're challenged with, especially when we launch a vendor solution. For our internal AI products, what we do is we always have a working group, and then we build a dashboard to measure the performance, any drift, ongoing utilization. So for example, in the pressure injury use case, the leadership and the teams that work with that tool, like the managers, they get a report and they can see the compliance. How many patients were predicted positive? How many had an intervention? Do we have any gaps? And so we expect after a project has been launched that the stakeholders involved in that project are accountable for the ongoing monitoring. And then our data scientists are accountable for looking for model drift. And we have parameters where if the model starts to drift on performance, we get alerted, but also we can measure that through our dashboards, which do like a daily refresh. But we are thinking about how do we what will that look like at scale? Because we build out a lot of our homegrown kind of tools and dashboards, but longer term, do we need like an AI governance platform that could support the hundreds or maybe thousands one day of like agents in use cases? Because we're not sure yet doing it homegrown if it's going to be sustainable. I saw a question about being part of a LEED certified entity. How do you do environmental impact study prior to starting the use of AI? That's a good question. I think many of our internal AI tools we've taken a classic machine learning approach. So we're not doing a big training. Like I think some of the debate in the community is about when you create like the next GPT and they're using billions of dollars and lots of energy. But our models, generally when you're using things like structured data, laboratory, we use a lot of notes with structured data like lab values and vital signs. We're not using a tremendous amount of energy in compute. So yeah, it's a good question. I think if we start going into more energy intensive use cases, yeah, I think that's going to be important, measuring the environmental impact. Okay, I'm curious about the next question. I'm curious about the algorithm used to predict pressure injury scores. The slide you showed was labs, vitals, diagnosis, pretty common. Sense stuff. How did you determine the algorithm truly picked out patient at high risk? Okay, so, and did you analyze the current workflows before you did the intervention to prevent? Were there any patients who were not flagged for risk but should have been? Yeah, I think that great question, Catherine. So a couple of things. In many of use cases, and in this one, we had like a legacy tool to compare it against, and I'm happy to share our paper on this. We compared against the Braden score, so we had a benchmark. We knew, so we looked at who went on to develop pressure injury, how well did the Braden score predict that, and we could calculate all the standard kind of evaluation metrics. What was the sensitivity, specificity, the true positive, false positive, true negative, false negative, and then so that was our baseline, and then that was the score to beat, and so every time we've done this, we've been able to show that with machine learning AI approach, you could usually beat some of the legacy tools out there, like the Braden. And so many of them come from the days of paper. We just kind of built it into the EMR. And so we did that in this case. And I can put the link in the chat to our publication if you want to kind of read about how we built the model and how we benchmarked it against the Braden. The interventions are kind of known. It's things like turning and positioning the patient. It's things like having them on the right kind of mattress. There's interventions that are evidence-based to prevent the pressure injury. The challenge is the tool we were using was not the predictive power was not very high. So you had to apply those interventions to a large patient population. And what the pressure injury AI tool helps us be more targeted. So, on any given unit on the hospital, instead of focusing those interventions across 10 patients, we could tell you here's like the 4 to really focus on, and then we could be better stewards of our resources. And we've seen that to be effective. And so, yeah, I'll put that in the chat. I think I skipped one. How much alert fatigue from providers are you facing? I think especially, so that's alert fatigue is a real challenge. We've learned over time that sometimes alerting is not the right approach. And I'll give an example. There was a project where we were, for clinical deterioration, predicting who would end up either dead or in the ICU from the med-surg floors. We were sending an alert to the Epic apps, Haiku, saying this patient's at risk for deterioration. And we got a lot of, and it would go to our rapid response team. And we got a lot of the team would go see a patient, and we would get they were able to give us feedback, and we get kind of snarky comments like, I just had a lovely conversation with so-and-so who's looking fine and eating lunch. And then we would analyze the data, and many of those patients would end up crashing and end up in the ICU 12, 24 hours later. But we learned that sending those alerts wasn't as helpful as giving a proactive list. So we actually changed the approach to proactive rounding. So instead of firing off alerts at folks, they have a process now of just who are the highest risk patients. So one of our sites has 1,200 beds. You can round on those subset of patients, let's say the top 15 or 20 that are most likely at risk for deterioration. And that's worked much better. So we've kind of moved away from sending alerts and found that the most successful use cases has been just giving people a prioritized list. So we do that with our malnutrition AI model. We do that with pressure injuries. And that's been something that's been repeatable. Okay, Catherine, so I'll talk about that in a moment. So the question is, how do you reevaluate your algorithms for accuracy and look for bias? I'll pull back, open my slides, and I should like a couple more. I wanted to share, sorry, I'm just trying to get my Zoom screen back. I wanted to share one example that kind of stood out for me. Here we go. Because I'm a new parent, I have a small child at home. My daughter's under 1 year, almost 1 year old. But some work that we're doing with our smallest patients in the hospital, in our NICU, and it was really inspired by an adverse event. And so there was neurological injury can lead to lifelong challenges, right, for patients if we don't address it proactively. And we know that video AI has gotten better, right? Just look at kind of what we're seeing with self-driving cars and other vision AI model advances. And so there was a case where a neonate had a spinal cord bleed. They ended up getting brought for surgery. Neurosurgery brought them in, but despite the best care, they ended up with permanent paralysis below the hip. And so that inspired us to ask, could we do better with AI? And that's translated into this NICU Vision AI project that we recently launched a prospective trial for, to continuously look for neurological events with the babies and then get in early with an intervention. So our initial model, this was the training. This was our performance on the training and the holdout set, looking at, can you predict the neurological events with the neonates? And I want to give a shout out to our research team led by Dr. Ben Glicksberg, who's leading this work in our Department of Children's Health and AI at Mount Sinai, who's now partnering with NICUs around the country to do a validation for the trial. And so we were able to see in the initial training set that we're able to predict these neurological events earlier, and now we're running the prospective trial to validate that. Very inexpensive. You can take a simple smartphone, put it on the bassinet, and leverage these vision AI models. There's been a lot of focus on voice ambient solutions, but I think that the vision models are going to unlock a lot of value for us. So that's one example in the NICU, but we're also working with a company around vision models in the inpatient setting. And then I think at the home is just the inevitable next step from there, to use vision to unlock some new use cases. Okay, so there was a question in the chat about assurance. I want to spend a moment on our assurance process. So we have an assurance lab that does the testing and validation for AI models. That includes gathering the information, doing a risk assessment. That helps us prioritize where we need to use our assurance resources, because each one of these takes amount of time and effort to test how they work. We do the assurance and validation, and then we make a recommendation back to our governance committee around did the model meet our success criteria. That includes looking for bias, checking the prospective performance. It's pretty straightforward for the classic AI models. With generative, we're still working through like the best approach. And so I think there's more for us to learn on how we'll do this for the generative models as well. But we do have human review, and we're still trying to kind of perfect, I think, how we'll monitor for the generative use cases. But assurance is something that we do for all the high risk models. And then we do ongoing. So we'll do the initial assurance, and then we'll have ongoing monitoring tools to look for model drift or changes in performance, which do happen. Documentation patterns happen. We've had things like changing from pounds to kilograms, where we made an EMR change that impacted a few of the models that were using weight, a weight flow sheet. And so having that ongoing monitoring is really important, so we can flag really early if something changes with performance, and we can then get down to the root cause if something changes. We also look at, sometimes we'll do, if there is bias that we find in the model, sometimes you can add a fairness layer in how you implement it. So an example of that was a model we did for patient experience, where there's a lot of bias and racial bias in patient experience data that's been known and kind of for a long time. And so our intervention on that model is we have the patient rep go and round proactively. So what we do is we add a fairness layer so that the patient rep will see demographic that is representative of that hospital where they're working. So they'll go out and see a representative sample of patients every day. So that fairness layer helps us make sure that they're not just rounding on white men. As an example, they're going to round on a patient population that reflects the population at large. Okay, so to kind of tie it all together, I wanted to just summarize some of the things that we've learned over time. You know, it's really more than a model. Creating the model, especially now with you know, copilots and agents, like it's very straightforward. And I think the barrier is going down, and the agents can do a lot of the modeling. But the way the change management and the adoption piece is like 95% of it. Once you have the model, you're only a few percent there. There's a whole lot more work to do. And that's where the experience-led approach comes in. So I gave some examples of how we partner with our clinicians, with our patients to co-design these tools. And that's always worked best. We do break the work down into small agile pods that are cross-functional. So all of the team members needed to bring a project to life will work together on a cross-functional pod, and then having robust governance. So everything goes through our enterprise. Digital and AI governance, that's where we prioritize, approve the work, and then make sure that the right projects are going through the right steps in terms of assurance and risk ethics and policy. With that, I'll take down the slides, and I'm glad to answer, you know, any last questions. I do appreciate everyone, you know, taking time to hear a little bit about the work that we're doing. Okay, I saw a couple of questions come through. How often do you train AI for new scenarios in healthcare? One thing we do that I didn't talk about is we'll often do like a retraining. So for example, we may have an initial model, and then we could bring in more data assets and improve that model. So example of that is we have a model we built for delirium, identifying delirious patients in the hospital. We started with structured data, and now about a year ago, we deployed the second version, which is the structured data and all the notes. We got a really nice boost in performance by doing the newer version. And so we'll you know, periodically retrain and redeploy new versions of the model. How do you determine high risk versus medium versus low? We're a member of Mount Sinai is a member of CHAI, Coalition on Healthcare AI, and we partner with them on their risk assurance framework. They have some resources on the website, and we use a scoring criteria that was developed through one of the work groups. And lastly, if I recall correctly, you mentioned earlier that you allow clinicians across the board to submit requests. Yep. What systems we have set up to? So we use ServiceNow. That's our help desk tool. So people go into ServiceNow. We have some structured, like required information that we ask you to submit, and they can do that through ServiceNow. We've tried to streamline that process, but make sure we collect the minimally necessary information to evaluate the request. Okay, I think we've got through a lot of the questions. Sierra, is there anything from your end that I may have missed?
No, I think we've hit most of the ones that have been posted in the chat so far. If people have additional questions, feel free to continue posting those in the chat, or you can raise your hand and unmute.
I actually have a question. I
Sure.
think you talked about a little bit about like the organizational structure in the beginning of the presentation, but can you give a little bit detail about like the team that actually does this work? Like what does it entail? How big is it? What's the process, right? Like if an organization needs to replicate, like what does like the funding for such a team looks like, if you can share? Yeah.
Sure. So one thing to say about the organizational structure is that we've kind of centralized a lot within our technology department. So we have a chief digital information officer who's also our dean for technology. So anything we're doing both on the school, like within the research and school enterprise, the health system operational enterprise, we all sit in one department, and then we have cross-functional teams. So I have a peer who's our CIO, who has all the applications, and I have another peer who's our CTO, who has the infrastructure. And then we'll people will work together on a cross-functional pod. So an example of that is, we have a pod for care navigation. And so we may include some of the work we've been doing on that pod includes we have these checklists for patients that we call My Next Steps. The patient comes for a visit with a doctor. At the end of the visit, they get a checklist, something digital checklist of like, you got to fill your meds, you got to maybe follow up with a specialist, and here's some education. That pod will have the MyChart analyst doing our app development. It'll have a product owner, a designer who's designing the user experience. It will have a product manager that's responsible for the overall journey, for the care journey. And so those are all example of roles that sit within my team, our digital AI experience team. We also have, in terms of doing internal AI development, it's not a huge group. We have about 12 full-time people. That's a mix of data scientists, machine learning engineers, but we often rely on other colleagues in the technology department. So an example of that is we use a lot of real-time data. So when we need new data fields, we'll work with our interface team to configure, let's say we need notes from the emergency room as an example. They'll configure those interface feeds to send to us so our data scientists can do the modeling and then our engineers can deploy the model. And so, yeah, my team's around, our technology department probably has about 1,000 people, roughly. Yeah. And my team has about 10% of that. So many of the technology team members sit outside digital and AI. Probably close to 100 are within digital and AI.
Awesome. Thank you. And are there any of these like products that you've built and scale across Mount Sinai? Have you done any like technology transfer to build like products and companies? And how is that? Like, how can we scale some of this if that's work good across like other health systems?
Yeah, there's a couple examples of that. Some of our AI tools we've licensed out to third parties. We've partnered with platforms like there's one called Musum Health that we work with, where they deploy our malnutrition AI models. And that's something we're really focused on, is how we can also bring things to market so that way other organizations can realize the value of the tools. And then Mount Sinai broadly has done a number of tech spinouts. We have many innovative like research labs as well that may work on projects that also will go through the tech transfer office. But yeah, our team has done mainly licensing agreements so that other companies can then sell our products in the market.
We have another question from the chat. How integral are the practicing providers and care teams in your different teams created for these AI projects?
Oh, it's like critical. And so many of us have come up through the trenches. So like my background, I started my career here working with patients at the bedside. Our team has many physicians, nurses, and then we partner with the operational kind of leaders across the clinical settings. Like that's key. I think being close to the end user. And then in some cases, like the work we're doing for the workforce, that may look like partnering closely with the team that runs our access call center, or the team or our HR teams as well. So depending on the work we're doing, we need to be really close to the leaders and the folks doing the work. And certainly for all the clinical projects, we have to be really closely aligned with the care teams in the areas that we're working with.
I have actually another question for you.
Sure.
Sorry. How are the decisions around decommissioning made? Have you like looked at any projects that didn't work out or like were not adopted?
What a great question.
Yeah.
That's like that's one of the hardest things sometimes, is to say this project was not successful. And so long as our teams are so motivated to keep pivoting and do everything to make it successful. And so we do a portfolio review every quarter. And part of that includes asking the question, if we're not getting the right adoption to what do we decommission. There's a tax you pay for every product we support. And so we don't want our team spending time supporting a project that doesn't have utilization. And what's helped the most is having clear success criteria. So it's clear cut, are we meeting that success criteria or not? And what's hard is when things are on the fence, where we're almost there, and like then we're almost there for a long period of time. And so we try and use our best judgment over on what to decommission, but we've had to decommission many of the project. Not, I wouldn't say many, but we do decommission, fairly often when we don't have the adoption that we need.
Yeah, and do you own that decision, or does it have to run through your governance board? Or yeah,
No, we have a working group that's part of governance
yeah,
that meets regularly around the portfolio, and that working group can make a recommendation for decommission. And though generally, like we try to make it straightforward. We haven't met that success criteria, so the next step is to decommission. But yeah, I would say we could probably do a better job in how we then report that up through
yeah,
governance. But
yeah.
we do have a like a steering group around the internal
Mhm.
products that helps determine what we decommission.
Thank you. I have actually one more follow-up question on a previous one. You had talked about using ServiceNow for kind of vetting those product requests. One thing that we've often heard from health systems is that when they kind of open it up to clinicians, there are so many requests that are coming through as we're kind of in this AI hype
Yeah.
moment. How do you deal with kind of that volume of requests and set up your system so that you're able to kind of quickly prioritize what is a good use case versus maybe what might not be?
Yeah. We're certainly seeing that. And so we're getting a lot of requests, more than we can work on. Part of it is how we do like a quick triage. So sometimes when we triage those requests, we find out that someone may be requesting something that already exists. They may be requesting something that's not feasible at this moment. And so there's a subset that just can get immediately kind of addressed. But then the ones that the rest will go through our RICE framework, and then we can prioritize. But we get a lot more requests than we're able to work on, and we try and really make sure we work on problems that are highest impact. So that means there's always going to be some that we are lower in the backlog. Um, and the other challenge is just this agent sprawl, like all the platforms. We use Oracle as an ERP. They're rolling out lots of agents. Epic's rolling out lots of agents. ServiceNow has their agents. So just trying to get our arms around kind of any new agent to kind of bring it through governance before it gets turned on. It's probably one of the biggest challenges. And we want to try and stay ahead of that, but it does move, it's moving pretty fast.
Awesome. Thank you. Any final questions from folks before we wrap up?
If nobody has a question, I have one final question.
Sure.
Sorry. Thank you so much. This is so interesting. So, one of the questions that I had was like, after you've done your pilots and development of internal tools, like, do you require, as people submit these ideas, that the operational department, so wherever the tool is going to sit, have some budget allocation for monitoring maintenance or for development, or is it all part of the technology office?
We haven't done that. We haven't charged anything to the departments, but we do make sure that it's solving something that's aligned with the organizational priorities. But no, we are in our technology department, we fund the resources that keep the platform and the maintain the products. Well, thank you so much for the invitation. It was wonderful coming and chatting with everyone today. Feel free to connect online as well. I'm on LinkedIn and would love to keep the conversation going. Thanks, everyone.